Hello, everyone. I'm glad to be here today. My name is Caio Moraes. I'm from Brazil. And today I'm going to present about chest electrical impedance tomography. This is part one of a series of presentations that we will have here in the channel. So in today's presentation, I'm going to talk about basic principles of electrical impedance tomography. I'm going to present some validation studies and share examples of its clinical use. I declare conflict of interest with Timpel Medical for this presentation, and let's start. So, electrical impedance tomography, EIT, is a non-invasive and radiation-free technology used to create images of the intrathoracic structures using information from electrical potentials measured at the surface of the thorax. EIT was developed during the early 80s to assess ventilation and perfusion distribution in patients under mechanical ventilation. And for medical use, we need to place some electrodes around the chest wall to measure the change in electrical impedance. This CT image is illustrating the positions of the electrodes around the chest wall of a patient. The respiratory system has the advantage for EIT application compared to the other body regions because only the lung and the heart change the electrical impedance during the respiratory and the cardiogenic cycle. In contrast, bones and other tissues such as muscles remains stable during the respiratory cycle and cardiogenic cycle. The array of electrodes is typically placed in one transverse plane, although oblique placement has also been described. The electrode placement is generally placed in the 50 to the 60 intercostal space at the parasternal line that allow us to have a good assessment of ventilation distribution. And in general, we do not recommend to place the electrodes below the 60 intercostal space in supine subjects because the diaphragm may periodically enter the measurement plane. This is a simplified diagram summarizing how lung impedance change due to the current application. In this, we have two electrodes, one acting as an injector and the second as a receiver, and the red circle represents the alveoli wall. Note that from end expiration to end inspiration, the alveoli wall becomes longer and thinner, make it much more difficult for the electrical current moving from side to side. Then, EIT image and the waveforms represent the image change over time, and an increase in intrapulmonary gas volume increase the impedance, while the exhalation decrease the impedance. During an EIT examination, a very small alternating electrical current are applied through pairs of electrodes, while the remaining electrodes measure the resulting voltage. The set of EIT data acquired during a cycle of current application and voltage measurements produce an EIT image. The advantage of EIT over CT is the frequency of image acquisition. Current EIT devices produces up to 50 images per second, allowing the assessment of lung conditions in dynamic situation bedside close to the patient. The EIT image orientation is similar to that used by CT, with the right side of the chest located to the left side of the image and the anterior region at the top of the image. So, what does ventilation imaging represent? Generally, the brightest pixels indicate an area with the highest electrical impedance variation. Conversely, the darker pixels indicate an area with lower variation in electrical impedance. The waveforms on the right side illustrate the difference in amplitude of impedance related to the change in respiratory cycle in a bright and in a dark blue pixels. The pixels in gray represent areas without a significant change in impedance, such as regions with muscles and bones. And if we consider gray areas inside the thoracic cavity, this may indicate that the lung is not ventilating well, is not functioning as it should. And as you can see the waveform, we have a flat line showing no change in ventilation in that area. So in this case, the absence of ventilation in the posterior right lung may occur due to lung collapse, consolidation, or pleural effusion. So this image suggests the need for additional investigation. Different types of regions of interest are used to characterize the ventilation distribution. The most common method is splitting the lung into quadrants, anterior right, anterior left, posterior right, and posterior left. We can also divide into just anterior, posterior, right, and left, or divide the lung into multiple ventral to dorsal layers if we are interested in more detailed gravitational physiology. The first CAT prototype was developed in UK during the 80s, called Sheffield EAT. Few years later, Dr. Marcelo Mato and other professors here at the University of São Paulo decided to develop their own EAT device. And this is a bench test of one of the first prototypes in our university. Many animal studies were performed in our lab, comparing EAT with CT scans. And this figure shows some assessment at the hospital of the University of São Paulo in 2004, 20 years ago, a long time ago. And at that time, the electrodes were placed one by one with the same spacings. And as you can imagine, an assessment at that time used to take a long period. Fortunately, commercial EAT systems for clinical use have created belts with electrodes that make the application much easier. And this is the device that we use in our ICU, commercialized by Timpel Medical. And this device was the first approved in US by FDA a few years ago. This video illustrates how easy it is to place the electrodes on a patient. We prefer to place a patient in one side, generally the left side up first, and then we attach the electrodes starting at the backbone and keeping the electrodes aligned in the 50 to 60 intercostal space from the paraesternal area. Then we flip the patient to the other side, and we can fix the remaining electrodes in the right thorax. And once we are done with this, we are ready to start the monitoring process. This is the main screen of ENLIGHT. In the center, we have the dynamic image showing cycle by cycle where the tidal volume is moving in different lung regions. We have the ventilation map that quantifies, in this case, the anterior, posterior, right, and left tidal volume distribution, and also the plethysmogram showing the tidal change in tidal volume and expiratory lung volume. So what about the validations of those measurements about lung ventilation? This was one of the first papers published in Blue Journal by Dr. Victorino and Dr. Marcelo Amato in 2004. In this study, the authors compared the change in electrical impedance with computerized tomography, dynamic CT, in a population of critical ill patients under mechanical ventilation. Among the variables from CT, the change in absolute gas content was the best explained the change in electrical impedance. And as you can see, there is a strong relationship between those two variables with a R-square of 0.92. So electrical impedance can reliably assess the ventilation distribution during mechanical ventilation. In this study, the authors used the Sheffield EAT system with 16 electrodes placed around the chest, and this image illustrates the schematic regions of interest on the CT and EAT. And as you can see, multiple regions of interest were considered. This slide shows CT and EIT from the beginning of inspiration till full inspiration. This was a low flow maneuver, and we can see from the CT image that only one lung, the left lung, changed the density, changed the shades of gray, suggesting only one lung ventilation. And the EIT image agrees with this assessment, suggesting change in electrical impedance in only one lung and much higher, illustrated by the white pixels in the anterior part of the left lung. Here, another case, we have some pleural effusion and atelectasis in the dorsal part of the lung from beginning of inspiration till the end of inspiration. And clearly, the atelectatic zones and the pleural effusion remain silent. And EIT, again, in this image, suggesting only anterior change in the ventilation distribution, not in the dorsal part. Finally, this is an interesting example of how EIT can help to understand bedside physiology. This graph shows a low PV curve, a low flow maneuver. Here we have array pressure in the x-axis, and in the y-axis we have volume. And please note this bizarre curve with a drop in the airway pressure in the middle of inflation. With EIT, this image shows that the beginning of inspiration, we have only gas moving to the left side. At a certain point, the left side starts to be overinflated, and then suddenly we have the right side inflating. So this drop in the pressure is because we have now more areas being inflated due to the heterogeneous lung behavior. So with EIT, we can understand much better the regional effects of disease. This is another example assessed in our lab comparing CT and EIT. In this case, we can assume that the ventilation distribution is homogeneous, suggesting that the functional lung size is equal to 100%. In another case, we have a pleural effusion in the lower part of the right lung, and no ventilation change is shown using EIT, and suggesting that we have almost 75% of the functional lung. Another example, a selective intubation with only one lung well aerated and EIT agreeing, showing that only one lung is functioning well. And the last one, bilateral pleural effusion, showing only aeration in the ventral part and EIT agreeing, suggesting function only in half of the lung. More recently, we discovered that the EIT image represents in average a slice of about 15 centimeters of the lung. So means that we are measuring more information than the size of the electrodes because the current move in that direction. And if we consider an average adult, 15 centimeters is almost half of the lung size. So we have a good size of information. This is a summary of the previous validation studies. Here we have a list of papers showing the bias and the limits of agreement. The bias is the average error, and the limits of agreement represents the range within which most of the difference between EIT and CT, or another gold standard, are expected to lie. So let's see an example to understand the clinical meaning of the limits of agreement of 10%. In this case, we have an illustration of a patient with about 15% of ventilation in the right lung. And we know that in a normal condition, that should be about 50 to 52% in the right lung. So if this patient has a normal lung, we can expect a maximum measure of error for this right lung hypoventilation up to 40%. That means 50 to 52 minus 10% of limits of agreement. And in this case, we have a patient with 15% of ventilation distribution. That means that we are far from the error band. Thus, in this case, we have a high chance of having a patient with a true problem, such as atelectasis or consolidation. And this image also shows that mainly the left lung is functional. In fact, this left lung is receiving what would be proportional to 12 cc per kg. And the CT image of the same patient shows a huge regional pneumonia in the posterior right side of the lung, agreeing with the functional information collected by EIT. Now, I'm going to introduce some basic principles of perfusion assessment using the EIT and why assessing regional lung perfusion. Because an efficient gas exchange is the result of an intimate matching of regional ventilation and regional perfusion across the alveoli. There are many methods to assess perfusion distribution using EIT, and the most common is using an injection of hypertonic saline into a central venous catheter, where we can visualize the passage of this contrast through the lung tissue, and thereby detecting failures of filling. This video illustrates the passage of the saline bolus. Here we have the injection of the saline solution moving through the heart, the lung ileum, and then the right and the left lung. This is one example of an animal with normal perfusion distribution assessed by CT scan and EIT. Here, the more red to white pixels shows areas with more perfusion distribution, and both methods suggest bilateral normal perfusion distribution. Then our colleague inflated a Swan-Ganz catheter into the left pulmonary artery, and as you can see, CT is showing a reduction in perfusion in the left lung, and the EIT is agreeing with this difference in perfusion. Then we place a catheter into the right pulmonary artery. And again, we have some change in perfusion distribution, and both methods suggesting the right spot of perfusion assessment. This technology was validated in this interesting study by Dr. Borges and colleagues in Sweden, where they used EIT and SPECT-CT to measure the distribution of perfusion into different animal models. And we can see, for instance, that if we have normal ventilation, the perfusion is pretty regular in the right and the left side, comparing EIT and SPECT-CT. If we have, for instance, atelectasis of one lung, the perfusion distribution is shifted to the other side, probably due to the vasoconstriction reflex. And this is a more recent paper that we published in Anesthesiology from our colleagues from Pennsylvania, showing a good correlation between CT assessment of perfusion and EIT assessment of perfusion, with a limits of agreement similar to ventilation, lower than 10%. Now, let's see some clinical use of EIT ventilation, perfusion, distribution, and the plethysmogram. So I would like to first start in understanding the disease. This is interesting because most of the ventilatory variables that we have at the bedside are not enough to understand what is happening with our patient. We know that CT scan is a good method to differentiate if the disease is focal or non focal, but it's not feasible for most of the patients in our ICU. So we decided to use EIT to differentiate patients with focal to non-focal disease. This is a recent paper we published in Respiratory Care suggesting this approach. In this paper, we divided patients according to the hypoventilated lung areas. For instance, this patient in the phenotype 2 is suggesting a bilateral dorsal area that is hypoventilated. In the case 3, we have only one quadrant, one dorsal part of the lung that is hypoventilated. And we may have patients like this one with normal ventilation distribution among the quadrants. What is interesting to see is that global respiratory parameters, such as respiratory compliance, are not sensitive to detect this change in respiratory regional function. And for instance, driving pressure looks protective in those two cases, but we have two different patients. And we may feel comfortable having a driving pressure lower than 14 in a patient like this, but once we have this kind of image, we may start thinking about improving the dorsal area, for instance, using prone positioning or increasing PEEP, and we may improve much more the mechanical ventilation decreasing driving pressure. Currently, we are proposing this update of respiratory phenotyping using EIT, splitting this normal ventilation distribution between low and high compliance, because this may enrich our capacity to measure the respiratory function. And this is a nice example. Looking for frequencies of phenotypes, we were able to see that most of the patients with COVID ARDS shows the phenotypes 2 and 3 that are patients with dorsal lung disease that can be bilateral or unilateral. And look that combining both, we have about 70% of patients with these two different phenotypes. And this result may suggest why prone positioning is so effective in improving respiratory function, because most of the patient has problem in the dorsal area. And we were also able to see that patients with normal ventilation distribution are not so well in prone positioning. And if we consider only the PF ratio, we can see that we are almost unable to distinguish those different lung images. We can also use EIT in neonatals and pediatric populations. This is a case with a 39-week gestation male infant that was admitted in our ICU. And the chest X-ray revealed abdominal content in the left thorax, and we have a suggestion of a large hernia. And the EIT image is suggesting a heterogeneous ventilation distribution with about 90% of ventilation in the right side. The infant was sent to surgery, corrective repair of the diaphragmatic hernia, and the EIT image post-surgery shows a significant improvement in ventilation distribution among both lungs. So we believe that the early recognition of continuous assessment of ventilation heterogeneities might be useful to avoid lung overstretch, in this case during artificial ventilation, which shall impact in better outcomes for those infants. Second, we need to monitor the effect of respiratory interventions. Here we have a common situation, a patient before and after open endotracheal suctioning. The plethysmogram shows a reduction in end-expiratory lung volume when the ventilator was disconnected and the suctioning started. And once the ventilator was reconnected, we can see that the end-expiratory lung volume is still far from what it was before. And the tidal change that is correlated with tidal volume is almost half of it was before. So in this case, at the bedside, in a few short of period, we can see that something is wrong. And combining with the ventilation image map, we can see that the dorsal part is gone and we have a heterogeneous ventilation distribution. So we can decide to maybe recruit the lung or do some maneuver to restore the lung function. Sometimes the end-expiratory lung volume is restored in a few period of time, in a short period of time, as you can see here, but that's not the rule for most of the patient. And this depends on the ventilatory mode and the kind of suctioning that we are proceeding. So it's important to understand the effect of our interventions. Another example, here we are applying PEEP, trying to recruit the dorsal part of the lung that at PEEP 5 was about 31%. Note that when PEEP was increased from 5 to 20, the ventilation distribution in the dorsal part increased significantly, and up to 25, we have the dorsal part fully recruited. So we have an example suggesting a good response, a patient with high recruitability, and there is no need to keep on going increasing PEEP because we don't have any major change after that time. We can also increase the safety of our patient during this kind of procedure. Here we have a paper that we published a few years ago describing how EIT can be used for that purpose. The dark blue area is representing changes in PEEP. So as you can see, we have an incremental PEEP and decremental PEEP trial. And the light blue waveform shows the change in end expiratory tidal volume and the change in regional tidal volume, the regional ventilation. And as you can see, as PEEP is increased, the end expiratory lung volume increases. When PEEP is decreased, the end expiratory lung volume decreased. But in this case, in this patient, we can see something really weird. At a certain point during the middle of the recruitment maneuver, the EIT plethysmogram was keeping increasing. We reduced PEEP and the plethysmogram was still increasing. And what this phenomenon suggests that every breath is not being exhaled. We are keeping some air inside of the chest cavity. So we are producing a pocket of air inside the pleural space that is the pneumothorax. And as you can see, we have almost one part of the lung reducing the ventilation distribution. And these white pixels are the detection of pneumothorax. Once the chest tube was placed, we can see a reduction in the end expiratory lung volume and the ventilation distribution was restored. Third, we can use EIT to personalize the ventilator settings. This is a very interesting tool that we can use at the bedside to titrate PEEP. Using EIT, we can assess the distribution of overdistension and lung collapse at different PEEP levels during a decremental PEEP trial. EIT uses information of regional ventilation and driving pressure, so we can calculate regional compliance at different levels of PEEP, and we can see also the absolute levels of overdistension and collapse, and we can identify if the distribution of overdistension and collapse is homogeneous or heterogeneous. In this case, this image suggesting that the right lung is healthier than the left lung because at higher levels of PEEP, we have more overdistension in the right compared to the left. And as you can see, with PEEP levels below 15, collapses start first in the left lung. In a recent paper published by Jacopo Fumagalli, we found that the crossing point of lung overdistension and lung collapse during a decremental PEEP trial matches with end expiratory transpulmonary pressure slightly positive. So we have a new way to measure something that from a physiology base, everyone believes that slightly positive end expiratory transpulmonary pressure represents a safe range of PEEP to avoid overdistension and collapse. And a non-invasive way, using EIT, the crossing point matches with this assessment. If you are interested in more details about this method, I strongly suggest you reading this physiological paper by Eduardo Costa, where they developed and they described all the calculations behind the overdistension and collapse assessment. And to finish this topic, this is a pretty recent meta-analysis published in Intensive Care Medicine by this group from Toronto, comparing the EIT guided PEEP with different other methods in ARDS patients. And in this meta-analysis, they were able to see that EIT titration PEEP using different methods, but most of them based on overdistension and collapse assessment, provides higher respiratory compliance compared to conventional methods such as the PIP table or global PV curves. And most interestingly, they were able to see that EIT favors a reduction in mortality as described in this forest plot, suggesting an important effect using PIP titration by EIT. And the authors conclude that EIT facilitates real-time, individualized PIP assessment, improving respiratory system mechanics, and the integration of EIT as a guiding tool in mechanical ventilation holds potential benefits preventing ventilator-induced lung injury. And finally, EIT can be used to allow a safe transition from control to spontaneous ventilation distribution. This is an interesting paper by Takeshi Yoshiba and our group, Marcelo Amato, published a few years ago, describing pendeluft in patients and animals under spontaneous breathing with a strong inspiratory effort. We know that this phenomenon called pendeluft is quite common and well described in patients with COPD and asthma, but that was the first time, 2013, that we were able to describe these in patients under mechanical ventilation. And what's the meaning of this phenomenon? Here we have airway pressure, flow, and the impedance change in the anterior part and the dorsal part of the lung. And as you can see, during controlled mechanical ventilation, both areas, ventral and dorsal, inflate simultaneously. But when we have a strong inspiratory effort, the patient is triggering the ventilator with a strong inspiratory effort, we may have this kind of phenomenon. The ventral part is deflating, as you can see the waveform, and the dorsal part is inflating. And what's the result of that is that the dorsal part is overstretched during spontaneous ventilation compared to controlled mechanical ventilation. This is an example of ventilation distribution during controlled mechanical ventilation and assisted mechanical ventilation. As you can see, the pattern is completely different. During control, the ventilation distribution is much more simultaneous and synchronous, and during assisted ventilation with a strong inspiratory effort, the ventilation distribution starts in the dorsal part of the lung and then moves to the ventral part of the lung. This is a pendeluft detector that we worked a few years ago to use EIT information to create this kind of maps that is representing areas with higher pendeluft. This method is interesting because here we can see, for instance, in this case, the global tidal volume is about 6 cc per kg, but the pendeluft area, these white pixels in this image, is receiving about 8 cc per kilogram. And how can it be possible this area receiving a tidal volume higher than the global tidal volume? Because this area with pendeluft is receiving most of the ventilator tidal volume plus the gas moving from the ventral part to the dorsal part. And that is the proof that pendeluft may induce overstretch in the dorsal part of the lung. And recently we published this paper using PET scan showing that in a high inspiratory effort model, we may induce regional inflammation assessed by PET scan, the white and yellow pixels representing here areas with more inflammation that matches with the higher pendeluft area. We can also monitoring these during the weaning phase. This is an interesting paper by Andrea Copodoro from Italy, from the group of Giacomo Bellani. And in this paper, the authors were able to see that some patients after failure in the SBT trial present more pendeluft when pressure support was decreased compared to another group of patients. And interestingly, patients with high pendeluft during the weaning process showed more CO2. And this is suggested by the authors as a mechanism that may deteriorate the respiratory function and may increase the work of breathing. And why? Because as we know, pendeluft is a moving of gas from one side to the other. And in most of the case, this gas is a dirty gas. It's a gas with low oxygen and high CO2 moving from one side to the other. So if we have this kind of phenomenon, we may increase the ventilatory inefficiency, increasing the respiratory workload, and then the patient will be in this cycle of inefficient ventilation and failing every time we need trial. Now I have one example of the clinical use combining ventilation and perfusion imaging. This is a patient with 60 years old with COVID-related ARDS with a progressive deterioration in gas exchange. At day 6, the PF ratio was 120. And we were able to assess this patient with volumetric capnography, and we found a 66% of dead space. And at that time, the ventilation was according to the ARDSnet table with a PEEP of 14 and FiO2 of 0.7. Then we used a DIT to assess ventilation distribution, and what we found was this imaging suggesting a normal ventilation distribution at a lower level of PEEP, by the way. So suggesting that the poor oxygenation was not probably indicated by a huge amount of atelectasis, because as you can see, the dorsal part was fully inflated. Then we perform a decremental PEEP trial, and we can see here from 20 to 6 of PEEP that while PEEP was reduced, we cannot detect an important value of collapse in blue, while overdescension was reducing PEEP by PEEP. And the titrated PEEP was 6 in this case, and we were able to reduce from 14 to 6 very fast because we were monitoring the lung function, the driving pressures, and the distribution of lung collapse and overextension. And as you know, to have this size of reduction in PEEP generally takes hours or days to reach that. Then we proceeded the perfusion assessment, and this was interesting. For instance, as you can see, in those two assessments, we have most of the perfusion in the left side of the lung, a few on the right side. And this is a suggestion of ventilation perfusion mismatching. The ventilation was regular, but the perfusion was not that great. In the following day, day 9, this patient was assessed with a CTPA, and as you can see, this image is suggesting a filling issue in the right lobe. Then, after thrombolytics, and at day 18, the patient improved oxygenation, and perfusion distribution now is suggesting a regular perfusion distribution in right and left lung, and a second CTPA agrees, showing regular perfusion distribution. So, take-home points. We believe that EIT is a clinical tool for real-time monitoring of lung ventilation and perfusion distribution. We can use EIT to understand the disease, to understand better why our patient is not oxygenating while combining ventilation and perfusion, understanding the regional ventilation distribution, differentiating the disease as focal or non-focal. And we can also keep on monitoring the effect of the respiratory interventions, such as recruitment maneuver, suctioning, body positioning therapies, stuff like that. And we can definitely use EIT to optimize mechanical ventilation and may improve in outcomes, as the recent meta-analysis suggest. If you are interested in this topic, I suggest you reading this interesting review that we published a few years ago in Critical Care. This paper is open, is free. And in this paper, we are describing most of the features that EIT can provide us at the bedside. So once again, thank you so much for your time. And I'm really happy to be here tonight. Thank you.